Here, if you notice. So as she raises her arms, ऊपर हाथ करिएगा, you can see there is a bit of depression or a depression that appears which is organized. So there is a confusion whether it is dimple or a tethering. Tethering is when dimple is like one thread holding on to skin and pulling it down. So it causes a smooth depression. But replace this thread with a crab now. So it hold at multiple places. That will cause tethering. So broadly that is the difference. Although people tend to use them interchangeably. But dimpling is characteristically infiltration of the ligament of Cooper. And with the skin inner layer getting stuck, will be directly over the tumor. That is tethering. And you cannot move. See, I'll just try and show you. As I try to move it, this is a lump.
Yes.
So as I move it, I cannot move the skin there. See that? So it is fixed. But is it पौधे orange? No. So is it involvement of skin? Not in the classical sense. Involvement of skin is?
Satellite nodules, podiorange or ulceration.
So ulceration, podiorange or satellite nodules is skin. That's a lump you saw, and there is an axillary node also. But like I told you, examine the normal side first to know the texture of a patient's breast, because sometimes nodules could be present as a normal presentation of a normal breast. So to compare it is the right way to go about it. Okay, so what should be done? She has come with an FNAC, which is the wrong way to approach it. We should do triple assessment, which is good history, examination, followed by imaging. No.
Sorry.
Imaging next. For women that are 40 and above with less dense breasts, more fatty breasts, mammography is the investigation of choice. But if the breast is dense, ultrasound / MRI could be an option. But ultrasound first. Ultrasound is in any case required also for the axilla. Today we cannot stage axilla without ultrasound examination. So clinical examination plus ultrasound for both. In addition, you may do mammography in a lady who's this age because she has got a fatty breast. Why fatty breast? Fat would look black in mammogram. What would it look?
Black.
What?
Black in mammogram.
The lesion looks white. So it will look like lightning in the clouds. So it will be more clearly visible. Like what?
Lightning in the clouds.
So lightning in the clouds will be more clearly visible. But if the cloud is white, you can't see the lightning. So white against white won't be visible. What would be white? Denser breast. So in a dense breast, mammography is not a good investigation because it will not be able to pick up the lesion which is white, and it will also take the parenchyma which is white too. So both are white, so white against white you may not be able to visit. Got it?
Yes, sir.
And third part is corneal biopsy, not a FNAC. That we'll have to get done. Why corneal biopsy? It will be able to tell you whether it's an invasive cancer or non-invasive. Invasion can only be seen when it has gone through the basement membrane. So you can't see that with FNAC. Grade of the tumor. Markers. Biomarkers, that is ERP, RHA, R2 which are important for planning therapy. And the lower false negative rates. So can you repeat it for me?
Yes, sir. So firstly, the infiltration, whether it has reached
Invasion.
and secondly, biomarkers, and thirdly, grading of the tumor, and lastly,
False negative.
false negative.
FNAC has more false negatives. Good.
Sir, sometimes they ask the difference between tethering and puckering.
Yeah, that's a good question. Puckering is, like I said, claw. It's a dimpling multiplied by more ligaments getting involved. Tethering is when there is a tumor and it is stuck to the undersurface of the skin. That is the skin, and that is the tumor. This is the tumor, this is the skin. So it is kind of fixed here. So you'll find on movement. At this point doesn't see, it's moving. You can't see that. But in a dimple, it will be smooth depression. That I cannot do with my hand. because it needs a very, it's like a, it will become like this. If I pull it the reverse, so this is a liquid of Cooper pulling, and it becomes almost like a cup shape. And dimple is usually a pretty side, isn't it? But pucker is not. Pucker, Pucker, is nothing but pucker. So when I don't mind it, this is the skin on the other side. I do what? Smooth depression. One ligament of Cooper. अब इसको पकड़ लिया गया है. This is puckering. Tether. Rest is free. Clear?
Yes, sir. Thank you, sir.
Thank you, sir. Yes, sir.
This is craniocaudal view. And this is medial lateral oblique. Huh? Craniocaudal is for what?
The craniocaudal view.
Whether the tumor is in the inner or the outer quadrant.
Middle.
Above is outer, below is inner. This is craniocaudal.
Yes, sir.
So this is outer quadrant. This is, if it was there, it will be inner quadrant. MLO, join the line from nipple,
To
pec major.
Upper and the inner, the lower quadrant.
So it is borderline here as far as, but this is classical. You can see the microcalcifications. And now here also you can see that there is some density. But then you're still able to make out. That's why you're not able to. If this was a completely fatty breast, you would find it will stand out. But you can see still the white against the black, which would be completely black if it was all fatty.
Yes.
It's still got some
Other side.
parenchyma, like you see on the other side. So there is this is suspicious for me. Microcalcs are there. Microcalcifications are very suggestive. There's a bit of architectural distortion also. So this is more suggestive for malignancy. Okay.